Ever wondered why awake fiber optic intubation plays a crucial role in medical procedures? This sophisticated technique is more than just a medical jargon. It's a lifesaver, a beacon of hope for patients undergoing surgeries and other critical procedures. Awake fiber optic intubation has become an indispensable tool in the anesthesiologist's arsenal, ensuring patient safety and comfort during some of the most daunting medical procedures. It is a technique that requires precision, expertise, and a thorough understanding of both the procedure and the patient's needs. It's not just about inserting a tube, it's about doing so while maintaining the patient's airway, ensuring they can breathe, and minimizing discomfort. It's a delicate dance between the anesthesiologist and the patient, a partnership built on trust and expertise. So stick around, as we're about to dive in to understand this intricate procedure step by step. When do we actually need awake intubation? This is a crucial question, as understanding the indications of this procedure is paramount. Awake intubation is typically indicated when traditional intubation methods are not feasible or safe. For instance, in cases where a patient has a known difficult airway, such as those with a history of previous difficult intubation, anatomical abnormalities, or extensive neck or facial trauma. Awake intubation is also used when a patient has a significant risk of aspiration, such as those with a full stomach or severe reflux. Another indication is the need for ongoing respiratory support, as seen in patients with severe respiratory disease or neurologic conditions affecting the airway. Lastly, awake intubation is often performed in patients who need to be awake for neurological evaluation during the procedure. Understanding when to use awake intubation is the first step in effectively managing these challenging scenarios. Next, we'll tackle the contraindications to this procedure. While awake intubation is highly beneficial, there are situations where it may not be the best choice. You see, not all circumstances are ideal for this procedure. Certain patient conditions or scenarios may complicate or even prevent the execution of awake intubation. For instance, patients with significant airway obstruction or severe respiratory distress may not tolerate the procedure. Similarly, those with severe anxiety or uncooperative behavior may also present challenges. Anatomical factors like the presence of an unstable cervical spine or limited mouth opening can pose additional hurdles. Furthermore, patients with a full stomach or predisposition to aspiration are at higher risk during awake intubation. Also, it's important to consider the clinician's experience and comfort level with the procedure. Awake intubation requires skill and familiarity with the equipment, which can be a limiting factor. Now that we've understood when to use and when not to use this method, let's explore how to gain psychological buy-in from the patient. Patient cooperation is key in awake intubation. But how do we achieve this? Well, it all begins with trust and rapport. You see, the success of this procedure is heavily reliant on the patient's level of comfort and understanding. So how do we foster this environment? First, we need to be open and honest. Explain the procedure in simple, understandable terms, emphasizing the necessity and the benefits. This not only educates the patient but also shows respect for their autonomy. Next, we need to demonstrate empathy, understand their fears and concerns, and reassure them that their comfort is our priority. Use a calm and soothing tone to help ease their anxiety. Finally, involve them in the process. By giving the patient control over certain aspects, like holding the suction device, we can help them feel more engaged and less powerless. Remember, a cooperative patient is a cornerstone of successful awake intubation. Now, on to the technical aspects of awake intubation. The first step in the actual procedure is the administration of an antisialagogue. Now you might wonder, what's an antisialagogue? Well, in the simplest terms, it's a medication used to reduce saliva production. Why is this important in awake intubation? Well, it's all about creating a clear path for the fiber optic scope. Excessive saliva can fog up the lens of the scope, making visualization of the airway anatomy challenging. There are several types of antisialagogues we can use, each with their own unique benefits. Let's talk about a few. First up is glycopyrrolate. It's a synthetic anticholinergic agent, and it has a knack for reducing secretions. It's a popular choice because not only does it dry the mouth, but it also reduces the risk of bradycardia during the procedure. It's usually administered intravenously about 30 minutes before the procedure begins. Next we have atropine, another anticholinergic agent. It's widely used because of its fast onset. However, it may increase the heart rate, so it's not recommended for patients with heart conditions. Finally, there's scopolamine, It's a potent antisialagogue, but it's less commonly used because it can cause sedation and disorientation. It's usually administered via a transdermal patch a few hours before the procedure. Remember, the goal is not to completely dry the mouth. We need some saliva to lubricate the airway. It's about finding the right balance. Too much saliva can interfere with the procedure, but too little can make the airway dry and uncomfortable for the patient. Also, it's important to note that while antisialagogues greatly assist in awake intubation, they are not without side effects. These can include dry mouth, blurred vision, urinary retention, and in rare cases, confusion or hallucinations. As with all medical procedures, the benefits must be weighed against the potential risks. With the antisialagogue administered, we can now move on to topicalization. Topicalization is a crucial step in awake intubation. It's all about preparation and comfort. Imagine you're about to paint a wall. You wouldn't just start slapping on the paint, right? You'd prep the surface first. Topicalization is similar. It's preparing the airway for intubation. So, why is topicalization important? The goal is to numb the airway. This reduces discomfort and gagging during the procedure. In essence, it makes the process smoother and more comfortable for the patient. Let's break it down into some simple, manageable steps. First, we need to choose the right topical anesthetic. Lidocaine is a popular choice due to its rapid onset and longer duration of action. Next, we need to decide on the form of application. This can be a spray, a gel, or a solution for nebulization. Each has its own pros and cons, and the choice will depend on the patient's condition and the anesthesiologist's preference. The application process itself needs to be thorough. It's not just a quick spray and go. The aim is to get the anesthetic to the mucosal surfaces of the airway. This means applying it to the back of the throat, the tongue, the larynx, and the trachea. Remember, patience is key. The anesthetic needs time to take effect. This isn't a process to rush. There are a few things to consider. The dose of the anesthetic should be kept in mind to avoid potential toxicity. Also, the patient's comfort throughout the process is paramount. So, to recap, choose your anesthetic, decide on the form of application, apply thoroughly, and give it time to work. Topicalization is not just a step in the process, it's a crucial component to ensuring a successful and comfortable awake intubation. And with that, we're now ready for the actual intubation. Now comes the core of the procedure, the intubation. This is where your preparation and patient cooperation come together to ensure a smooth process. First, let's address the tool of the trade, the fiberoptic bronchoscope. This device is a game changer. It's essentially a flexible tube with a light and camera at the end, allowing us to see inside the patient's airway. It's flexible, which means it can snake its way down the airway, around bends and turns, giving us a real-time view of what's going on. The first step in the intubation process itself is to insert the bronchoscope. This is done through the mouth or nose, depending on the patient's condition and comfort. Advance it gently, keeping an eye on the monitor to guide your path. You're aiming for the vocal cords, the gateway to the trachea. Once you've reached the vocal cords, pause for a moment. This is a critical juncture. You want to make sure the patient is comfortable and not coughing or gagging. If they are, pause, reassure them, and allow them a moment to adjust. Next, gently guide the bronchoscope through the vocal cords and into the trachea. This might be a bit tricky, especially if the airway is tight or there are anatomical challenges. But remember, patience and gentle manipulations are key. Once the bronchoscope is in the trachea, you'll see the bronchial tree, a series of branching tubes. Keep the bronchoscope in the midline and advance it until you see the carina, the point where the trachea divides into the two main bronchi. Now, it's time for the endotracheal tube. Slide it over the bronchoscope, using it as a guide. Advance it until it's just above the carina. Then, carefully remove the bronchoscope, leaving the tube in place. Finally, confirm the tube's placement. You can do this by listening for bilateral breath sounds and checking for equal chest expansion. And don't forget to secure the tube to prevent accidental dislodgement. And there we have it. A successful, awake fiberoptic intubation. It's a process that requires skill, patience, and a keen understanding of anatomy. But with practice, it becomes second nature. Let's recap what we've learned today. Awake fiberoptic intubation is a critical procedure, a powerful tool in the anesthesiologist's arsenal. It's essential for managing challenging airways, and its importance cannot be understated. We've explored the various indicators that guide us towards opting for this technique, from anatomical abnormalities to a history of difficult intubations. However, as with any medical procedure, it's not without its limitations. Certain contraindications might make it less suitable. These relative contraindications include severe respiratory compromise and uncooperative or agitated patients. It's a balancing act, weighing the risks against the potential benefits. We've also seen that the success of awake intubation isn't merely about the technical aspects. Psychological buy-in from the patient plays a significant role. Building trust, explaining the procedure, and addressing any concerns can go a long way in ensuring a smoother process. The actual procedure of awake intubation involves several steps, each with its own intricacies. We start with the administration of an anti-sialagogue to reduce salivation and make the process easier. Topicalization, the application of a local anesthetic, is next in line. This numbs the airway, making the procedure more comfortable for the patient. Our discussion led us through 3 different techniques for topicalization: the nebulizer, popsicle stick, and viscous spray. Each has its own merits and suitability depending on the situation. Nerve blocks may also be used to further enhance anesthesia. Sedation follows, but it's a delicate dance. It's crucial to achieve the right balance to maintain the patient's cooperation while ensuring their comfort. Finally, we have the intubation itself, a step-by-step process that requires skill, patience, and precision. With this understanding of awake fiber optic intubation, we can ensure safer, more effective medical procedures. Thank you for joining us today.